Imagine a horse, a magnificent athlete, suddenly and severely lame. One moment they're vibrant performing, and the next they're in immense pain, barely able to bear weight on a limb. What could possibly cause such an acute crisis? And how quickly can it turn devastating, really threatening their career, maybe even their life? Okay, let's unpack this. Today we're diving deep into a true veterinary emergency in horses, equine infectious arthritis, also known as septic arthritis or sometimes joint ill. And if there's one thing you're going to take away from this deep dive, it's that this condition is a race against the clock. Every single hour counts.
You're absolutely right. It's a severe and debilitating infection, usually bacterial, sometimes fungal, right inside a horse's joint. And we call it an orthopedic emergency because if it's not treated, quickly and really effectively, it can lead to rapid, irreversible joint damage. That means permanent lameness or even, in the worst cases, euthanasia. It's truly one of the most critical things we face in equine practice.
Wow. So our mission in this deep dive is to understand how horses get this critical infection, the sort of detective work involved in diagnosing it, the aggressive treatments required, and what the prognosis truly looks like. We're pulling from detailed veterinary texts, so get ready for a deep understanding of this really challenging condition. So if it's that devastating, how do these dangerous microorganisms even find their way into such a vital, protected space like a joint? And does it affect all horses the same way, or are there differences?
That's a crucial question. And it's fascinating, actually, how the route of infection often differs between foals and adult horses. For adult horses, the most common cause is direct inoculation. This means bacteria are literally introduced directly into the joint space.
How does that happen?
Well, think penetrating wounds, a nail, maybe a piece of wire, any kind of cut or laceration that breaches the joint capsule. Vets are trained to consider any wound near or over a joint highly suspicious, like really suspicious.
Right, don't ignore it.
Exactly. Then there's also iatrogenic infection. That basically means it's introduced by us during vet procedures. It's rare with proper sterile technique, thankfully, but it's a known sort of dreaded complication.
From things like joint injections.
Yeah, things like intra-articular injections, steroids or hyaluronic acid or joint taps, even arthroscopic surgery. It's a risk we always have to manage.
Okay, so that's adults. What about foals? You said it's different.
It is. For foals, the most common route is hematogenous spread.
Meaning through the blood.
Exactly, bloodborne. Bacteria from an infection somewhere else in the body, like an umbilical infection, maybe pneumonia, diarrhea, even an abscess, get into the bloodstream.
Yeah.
And then they travel and sort of seed the highly vascular lining inside the joint, the synovial membrane, often in more than one joint, too.
Huh. And why are foals so susceptible to that?
Well, it often comes down to their immune system, especially foals with failure of passive transfer, or FPT.
That's when they don't get enough antibodies from the mare's first milk, right?
Right. Precisely. They don't get that crucial passive immunity, so their immune system is compromised, making them much more vulnerable to these systemic infections spreading to the joints. And less commonly, for both adults and foals, infection can also spread from an adjacent infection, like infected bone nearby osteomyelitis or severe cellulitis right next to the joint.
That's really interesting how the age changes the typical route. I guess I would have assumed it was always external trauma. So what specific bacteria are we usually talking about here? Are some, worse than others?
Yeah, the specific pathogens can vary, and some are definitely nastier. In adults, especially from wounds or those iatrogenic causes, you often find common skin or environmental bugs. Things like Staphylococcus species, Staph aureus is pretty common after surgery or injections. Streptococcus species, too. But also various gram-negative bacteria like E. coli, Klebsiella, Proteus, Pseudomonas, especially if there's environmental contamination.
And mixed infections are common, you said.
Quite common, yeah. Finding more than one type of bacteria isn't unusual at all. And yes, some, like Pseudomonas, can be particularly resistant and difficult to treat.
Okay, and in foals, with the bloodborne route?
In foals, with that hematogenous spread, E. coli is very common. Also Salmonella, Actinobacillus E. coli, Streptococcus, and Klebsiella. And rarely you might even see fungal arthritis, organisms like Aspergillus or Candida, usually in horses that are already immunosuppressed for some reason.
Are there particular horses that are more at risk for this? Besides foals with FPT, I mean? Or is it just bad luck?
It's not just bad luck, no. Performance horses are generally at increased risk, more activity, higher chance of injury. And specifically, studies show standardbreds seem to be overrepresented.
Really? Why standardbreds?
Likely because of the frequency of intra-articular injections, those joint injections we mentioned used in that breed to manage wear and tear. It kind of highlights that double-edged sword of treatments, doesn't it? They help manage issues, but every needle poke carries a small risk.
Absolutely. Okay, so given how fast this thing can escalate, diagnosis early and accurate sounds absolutely critical. So if you're an owner standing there looking at your horse, what are the signs? How do you go from, something's not quite right to, oh boy, this is an emergency?
That's a really key point for owners.
Hmm.
The clinical signs often just scream emergency. The classic sign is acute onset severe lameness, often a grade 3 to 5 out of 5.
Meaning barely weight bearing or not at all?
Exactly, like three-legged lame.
Yeah.
They're really reluctant to put any weight on it or they physically can't. The affected joint itself will usually have obvious swelling, what we call effusion, and if you touch it, it'll feel noticeably warm and painful.
Okay. Any other signs? Systemic ones?
Sometimes, yeah, you might see systemic signs like a fever, especially common in foals, maybe depression, not wanting to eat. And of course, if there's a visible wound near the joint or significant swelling around the joint, that's a big clue.
You mentioned something counterintuitive earlier.
Oh, yes. If the joint is actually open and draining pus or fluid, the lameness and the swelling might actually seem less severe initially
Why is that?
because some of that pressure and the inflammatory gunk is escaping. So it can be misleadingly less dramatic at first glance, but it's still incredibly serious. And in foals, remember, you often see multiple joints affected, plus maybe signs of other illness like diarrhea or pneumonia, and that history of potential FPT.
So vet suspects infectious arthritis based on these signs. What's the definitive confirmation? The smoking gun.
The most definitive diagnostic step is absolutely synoviocentesis. That's a joint tap, followed by analysis of that synovial fluid. And it's crucial, really crucial. This is done with strict aseptic technique, like preparing for surgery. You don't want to introduce more bacteria.
Right, so what does the fluid tell you?
Okay, so normal joint fluid is clear, pale yellow, and really viscous, kind of like oil. But infected fluid is typically turbid, cloudy, sometimes even looks like frank pus. The color might be off, reddish or brownish. Viscosity is usually decreased too, more watery.
And under the microscope.
That's the cytology part. The cell count will be massively elevated, often over 20,000 cells per microliter in adults, maybe over 10,000 in foals. Normal is less than 500. And the key thing is that over 90% of those cells will be neutrophils. Those are the white blood cells that rush in to fight acute bacterial infections. Seeing that many just screams infection.
Can you actually see the bacteria?
Sometimes, yeah. You might even see bacteria inside the neutrophils, which is pretty definitive confirmation. Also, the total protein level in the fluid will be high, usually over 4 grams per deciliter, showing significant inflammation.
So the fluid analysis is key.
It is. But while cytology gives you a quick idea that, yes, it's infected, you absolutely need culture and sensitivity testing. That's essential to identify the exact bacteria causing the problem and, crucially, to figure out which antibiotics will actually kill it.
Does the culture always work?
Interestingly, no. Only about 60–75% of clinically infected joints actually grow bacteria on culture. That's why it's important to get a good sample, maybe 5–10 milliliters, put it in a special broth medium, and ideally get the sample before starting any antibiotics if possible. That boosts your chances.
Wow, okay. So you're not just confirming infection, you're identifying the specific enemy. What other tools help out?
Blood work can be useful. There's a protein called serum amyloid A, or SAA. It increases really significantly with systemic infection and inflammation. So it's a good marker both for diagnosis and for monitoring how well treatment is working.
What about imaging? X-rays, ultrasound.
Yep, diagnostic imaging plays a role too. Initially, x-rays might look surprisingly normal, especially in the first few days. But over time, maybe days to weeks, they can start showing signs of trouble, like inflammation in the bone near the joint, which is osteitis, or actual bone infection, osteomyelitis, or even cartilage damage.
And ultrasound.
Ultrasound is really helpful, often more so early on. It's great for assessing the amount of fluid and fibrin. Those are like sticky protein strands that gunk up the joint inside. And importantly, ultrasound can often help determine if a nearby wound is actually communicating directly with the joint capsule.
How do they confirm that wound communication?
Well, besides ultrasound suggesting it, the easiest and most definitive way is joint distension with sterile saline. Basically, you carefully inject sterile saline into the joint under pressure. If that saline starts leaking out of the nearby wound,
then you know there's a direct pathway.
Exactly. Simple but incredibly effective test. Ultrasound is also great for looking at tricky joints like the hip or shoulder, where swelling might be less obvious externally.
Okay, so we've got the diagnosis, we know it's bad, we know it's urgent. Let's talk treatment. Given everything we've discussed, How does a vet even start to tackle this? What are the main goals?
You're right, it's go time. Aggressive and prompt treatment is everything. The goals are really clear and ambitious. 1, eradicate the infection. 2, physically remove all that inflammatory debris, the pus, the fibrin, the toxins. 3, reduce the pain and inflammation. And 4, crucially, protect the articular cartilage as much as possible to try and preserve future joint function. We're fighting on multiple fronts simultaneously.
What are the actual weapons in this fight? How do you physically clean out an infected joint? Sounds like a major plumbing job.
It kind of is. The cornerstone is a multi-pronged attack. First up, joint lavage and debridement. This is critical. It's about physically flushing out the bacteria, the inflammatory cells, all that debris.
How do you do that?
One common method is through-and-through lavage. You place multiple large bore needles into the joint, one for fluid going in, one or more for fluid coming out. Then you flush huge volumes, liters and liters, of sterile fluid through the joint cavity, like power washing the inside of the joint.
Is there a better way?
Well, the gold standard is generally considered arthroscopic lavage. This is done under general anesthesia. A tiny camera, the arthroscope, is inserted into the joint. This lets the surgeon directly see inside, allowing for much more thorough removal of fibrin clots and any dead tissue or necrotic tissue. Plus, you get a direct look at the state of the cartilage, which is really valuable information.
And if it's really bad?
In really severe cases, with lots of fibrin or damage, they might even do an arthrotomy that's surgically opening the joint fully for really aggressive cleaning and debridement.
Okay, so flushing is key.
Yep.
What else? Antibiotics, obviously.
Absolutely. Antimicrobial therapy is started immediately. Usually we begin with broad-spectrum systemic antibiotics, something like penicillin combined with an aminoglycoside, like gentamicin. The idea is to cover the most likely bacterial culprits right away.
Before you even know exactly what it is.
Yes, because time is so critical. Then, once those culture and sensitivity results come back, usually after a few days, the antibiotic choice can be adjusted to target the specific identified bacteria more precisely. And this isn't short-term. Treatment often continues for weeks, sometimes even months, and always for at least 2-4 weeks after all the clinical signs have resolved.
How do you get enough antibiotic right into the joint?
Great question. We use techniques to achieve really high local concentrations. One major one is regional limb perfusion, or RLP. You place a tourniquet on the limb above the affected joint to isolate the circulation temporarily. Then you inject a high dose of antibiotic into a vein below the tourniquet.
So it floods the local area.
Exactly. It delivers a really concentrated dose directly to the tissues around and in the joint. We also often inject intra-articular antibiotics directly into the joint space, sometimes daily initially. And another option, often done during surgery, is placing antibiotic-impregnated beads or sponges right into the joint. These slowly release antibiotics over time, providing sustained local treatment. It's a full-on antibiotic assault.
Wow. What about pain and inflammation?
Crucial. Anti-inflammatory medications are essential. NSAIDs, like flunixin, meglumine, banamine, is a common trade name, are the mainstays for managing pain and reducing inflammation. It's really important to note, though, that corticosteroids, steroids are generally a big no-no. They're contraindicated in an acutely infected joint.
Why is that? They reduce inflammation, don't they?
They do, but they also suppress the immune response locally, which is the last thing you want when you're trying to fight off an active infection. Maybe much, much later, if chronic inflammation persists after the infection is completely cleared, they might be considered cautiously, but definitely not early on.
Makes sense. Anything else?
Yes. Supportive care is absolutely vital. This includes strict stall rest limiting movement is key, proper bandaging to support the limb and manage swelling. Cold therapy, like icing, can help reduce swelling and pain. Continuous pain management is critical for welfare. And sometimes horses might need IV fluids, and because they're often on NSAIDs for a long time, anti-ulcer medications are usually given too, to protect their stomach.
It sounds like a truly massive undertaking, both for the horse and the owner. Is there ever a point where it's just too much?
That's a very real and often difficult conversation we have to have. It's not just medically intensive, it's hugely demanding financially and emotionally for the owner. The commitment required for aftercare, medications, potential repeat procedures, it's significant. So we always discuss the prognosis, the cost, and the commitment needed right up front.
Okay, so let's talk prognosis. After all that intensive treatment, what are the chances? Is full recovery likely, or is it more about managing long-term issues?
The prognosis is always guarded. That's the first thing to understand. and it's highly variable. But if you take one thing away from this, it's that early diagnosis and aggressive treatment are absolutely paramount for a positive outcome. It truly, truly is a race against time.
What specific factors really swing the needle, between a good outcome and a poor one? What are you assessing?
Several factors weigh heavily. Time to treatment is number one, the single most critical factor. The longer that infection is brewing before effective treatment starts, the more severe and crucially irreversible the damage to the joint cartilage will be. That dramatically worsens the prognosis.
Okay, time is key. What else?
The root of infection matters. Generally, penetrating wounds, if caught and treated very early, might have a slightly better prognosis than, say, severe post-surgical infections or those bloodborne infections in foals. The specific involved joint, or joints, also plays a big role. High-motion, weight-bearing joints, think fetlock, hock, stifle, tend to have a more guarded prognosis for returning to full athletic function compared to lower-motion joints.
And if multiple joints are involved?
That significantly worsens the prognosis, especially in foals. The extent of damage seen during diagnostics or surgery is also critical. If there's already evidence of bone infection or severe cartilage erosion or lots and lots of fibrin clogging things up, the outlook is poorer.
What about factors beyond the horse itself?
Absolutely. Owner compliance and financial commitment are huge. This treatment is often long, it's expensive, and it requires intensive, dedicated care. If that's not feasible, the outcome is compromised. And finally, complications. Things like laminitis developing in the opposite healthy limb because it's bearing all the extra weight. That's a devastating complication. Or potential kidney issues from certain antibiotics like gentamicin. These can severely impact the overall outcome.
So putting it all together, what are the general outcomes people can realistically expect? How do survival rates stack up against actually getting back to athletic performance? Because those are really different things.
There are very different goals. With aggressive early treatment, survival rates themselves can actually be quite good these days. Maybe 85–90% survival for adult horses with single joint infections treated promptly. For foals, it's often lower and more variable, maybe 45–80%, depending on the study and severity.
But survival isn't the same as soundness.
Exactly. Return to previous levels of athletic performance is much more challenging and much more variable. For relatively uncomplicated cases treated very early, maybe a decent percentage studies report anywhere from 60% up to 80% in some cases might return to their previous job. But the reported range in studies is huge. It goes as low as 20%.
So a big range of possibilities.
A huge range. If significant cartilage damage occurs or bone lesions develop, chronic lameness and degenerative joint disease arthritis are very likely outcomes. Even if the infection is completely resolved, that horse might be pasture sound, may be suitable for light riding, but its high-level athletic career could easily be over. And foals, even those that survive septic arthritis, often have a significantly reduced prognosis for demanding athletic careers like racing later in life. The early damage can have long-lasting effects.
How do you monitor recovery? What are the check-ins after that initial intensive battle?
It's close monitoring. Clinically, you're watching for the resolution of lameness, heat, pain, and swelling. Those signs should gradually improve. Repeat synovial fluid analysis is really important. You want to see those cell counts, especially neutrophil percentage, and the protein levels come down towards normal. Repeat SAA blood tests are also very useful for tracking the systemic inflammation resolving. And imaging, like follow-up X-rays or ultrasound, helps monitor the healing process within the joint and check for any ongoing damage or secondary bony changes over time.
What an incredibly deep dive into a truly urgent and frankly quite scary condition. It's crystal clear that equine infectious arthritis is a serious battle, demanding immediate, decisive action from everyone involved, owner and vet team. From understanding those different routes of infection in foals versus adults, to the detailed detective work in the joint fluid, and that multi-pronged assault with lavage and targeted antimicrobials, it really is a testament to critical veterinary intervention.
It really is. And while, as we said, the prognosis just for survival has improved so much with modern vet care, that key takeaway remains. The chance of returning to full athletic function hinges almost entirely on the speed and effectiveness of that initial treatment. Any wound near a joint, any sudden severe lameness, especially after a joint injection, it needs to be investigated immediately. It truly is a situation where an owner's sharp eye and that quick phone call can make all the difference in the world.
So thinking bigger for a moment, if the fastest possible diagnosis and the most aggressive treatment are absolutely paramount to saving a horse's joint and potentially its life and career, What might this intense scenario tell us about the hidden, constant battles our own bodies and animal bodies are fighting against infection, and maybe the paramount importance of rapid, precise diagnostics in any medical field, human or animal? Thank you so much for joining us on this deep dive. We really hope this has given you some valuable practical insight into a critical aspect of equine health.